I'm one of the vets here at IMV Imaging. This month it is my choice to look at a paper, and I'm taking a gander at one on the diagnostic accuracy of ultrasonography to detect hepatic and splenic lymphomatous infiltration in dogs and cats. So welcome to the IMV Imaging Journal Club. Hopefully you've joined us before, but if you haven't, firstly, it's great for you to be here and watching the presentation. The presentations are popped out on demand for everybody to watch each month, so it's a different one each month. And we're quite happy for you to get involved. If you're watching this, you have the Q&A box via the little question mark indicator on your left-hand side. You can click that and pop in any questions you have, or you can reach us directly by emailing us on clinical@imv-imaging.com. So we're always happy to hear from everybody. And if you've got any comments or you've got any questions, let us know as well. So this month's paper, as I mentioned, is on lymphomatous infiltration in dogs and cats, and it comes from the Journal of Small Animal Practice. It was published this year. So it's quite a recent paper. So just looking and talking about lymphoma more generally, so lymphoma is a commonly diagnosed condition in dogs and cats, and ultrasonography features in the disease as part of diagnosis and as part of staging. So staging is important as part of the kind of grading of lymphoma for guiding a kind of prognosis as well, establishing which organs are involved. And it plays a part, again, staging, when we look at patients who are undergoing treatment for signs of remission as well. So ultrasound is good at looking for changes, but it's difficult because a lot of the changes that we see are not necessarily pathognomonic for certain conditions as well. So often our diagnosis, especially when it comes to things like lymphoma and a lot of other neoplastic conditions, they rely on FNA or biopsies as well. So that's something that we need to remember with these patients. Although ultrasound can pick up changes, it's not uncommon that we'll get FNA, we'll need FNAs or core biopsies for establishing a firm diagnosis. And there's a number of different presentations when we talk about the ultrasonographic appearance of lymphomatous infiltration in the liver and spleen. There's a lot of different presentations described as well too. So if we look at the image on the left, we're looking at starting with the liver. There's a number of different conditions, changes described that indicate lymphomatous inflammation. These could be more diffuse changes in echogenicity. They could be like the image on the left, which hopefully you can see has some target lesions. These are these lesions which have a central kind of hyperechoic core with a hypoechoic rim, traditionally sort of associated with metastatic neoplastic conditions as well. Moving into the right slightly and above, we've got another section of the liver where we've got a more diffuse kind of strong change in the heterogeneity of the liver tissue. There's more hypoechoic kind of nodular lesions throughout it as well. So a good variety in the types of changes that may be seen. Similarly, then moving on to the spleen on the right, we have quite a hypoechoic heterogeneous kind of lesion within the spleen. Again, this can be associated with lymphoma along with other more diffuse changes. And right over on the right-hand side, we have one of these classic sort of leopard spotted or moth-eaten or Swiss cheese-like appearances of the spleen, which again is associated with lymphoma. So there's a wide variety of these conditions seen in ultrasonography with patients with lymphomatous infiltration. So the aim of this study was to determine the sensitivity, specificity, and accuracy of ultrasonography in detecting lymphomatous infiltration of the liver, the spleen in a large population of dogs and cats. And it was also they wanted to determine if specific ultrasonographic features of these organs in dogs are more likely to be correlated with lymphomatous infiltration or the immunophenotype of the lymphoma, so whether it was a B cell or T cell type lymphoma. So this study was a retrospective study. The cases diagnosed with lymphomas over a 9-year period at a university teaching hospital. The cases had their diagnosis confirmed using cytology or histopathology, and they included cases that had diagnostic quality images of the liver and the spleen at presentation, and those cases had an ultrasound-guided FNA performed at the same time for cytological analysis as well. They excluded cases where they didn't have a detailed history available, where the ultrasound images were poor. They were looking at these from sort of still images taken in the past. And they also excluded any cases that had corticosteroid or chemotherapy agents in the 30 days prior to the ultrasound exam, as that may have quite a profound effect on the changes that could be seen as well. The ultrasound exams were performed using a wide variety of equipment, and this is probably a reflection of the fact that the cases came from a 9-year period as well. So there's going to be a different types of equipment, but generally they were always using microconvex or linear probes for it as well. And as it is a sort of teaching hospital, they're relatively high quality equipment. And when they were doing the FNAs, just for interest's sake, we're using 22 gauge needles in a 5 ml syringe without aspiration. So aspiration techniques when you're performing an FNA of the spleen have been shown to sort of increase the hemodilution of the sample. So often, initially, certainly it's indicated to do a non-aspiration technique, almost like a pin cushion, where the needle is just advanced and retracted quite rapidly within the region that we're sampling as well. So all the images from that period were reviewed by 2 board-certified radiologists who were blinded to the cytology results, and they looked at both the liver and the spleen in the scan, and they had they looked for these features. It wasn't these were multiple features could be seen in one organ in one patient, but these were the things that they were looking at: the liver and the spleen. Were the organs normal? Was there enlargement of them, so hepatomegaly or splenomegaly? Were there changes in the parenchyma, i.e. diffuse hypoechogenicity, a hyperechogenicity? Whether there was changes in the heterogeneity of the parenchyma as well, whether there is nodules present, and whether there's those target lesions, as we mentioned before, those kind of hyperechoic centers with hypoechoic rims greater than 2 centimeters as well. In the spleen as well, they were looking for that leopard spotted parenchyma sign that we saw on the previous slides as well. So that was the sort of splenic equivalent of a very strongly heterogeneous parenchyma. So when they looked at the reviewed these images, they were graded, each radiologist graded the images they got and how likely the lymphomatous infiltration of the organ was. So they graded them from 0 to 3, 0 being no suspicion, then 1 being low, 2 moderate, 3 high. And then they formed a consensus between the two radiologists together as to what grade it was. And any that were graded as 0 as 1 were considered negative, and any of those with a moderate or high suspicion were graded as positive as well. And then they went on to review the data, calculating the sort of sensitivity, specificity, accuracy, positive and negative predictive values, and their corresponding 95% confidence intervals for ultrasounds, the ultrasound detection of lymphomatous infiltration. And they also looked at independent variables from the ultrasound findings, i.e. which findings in the liver were associated with the presence or absence of lymphomatous infiltration. Similarly for the spleen, which ultrasound findings were associated with the presence or absence of splenic lymphomatous infiltration. And they also looked at the ultrasound findings that were associated with either T or B cell multicentric lymphoma. So as a result, there was 161 animals that met the study criteria, 132 dogs and 129 cats. And the median ages of the dogs were just over 8 years old, and cats are closer to around 10 years old as well, so middle-aged and older animals as well. In dogs, you see that the majority of the cases had multicentric lymphoma with smaller types of other presentations of lymphoma, i.e. GI, cutaneous, mediastinal, or others as well. In cats, there was more predominance of gastrointestinal lymphoma, more so than multicentric as well. And then generally B-cell lymphomas tended to be more common when they were diagnosed using cytology or histopathology than T-cell. Looking at the sort of ultrasound features that were seen in dogs, all of those features we previously saw were described in the patients that they assessed, the images that they assessed as well. In cats, target lesions were not seen in the liver or the spleen, nor were masses over 2 centimeters in diameter, and neither was splenic hypo or hyperechogenicity seen in cats as well. So a slight difference there. And especially in dogs, it was common to see multiple ultrasonographic features. When we look at the patients that had confirmed lymphomatous infiltration of the individual organs, we can see in dogs there were 57 with confirmed hepatic lymphomatous infiltration, 71 with infiltration of the spleen. In comparison with cats, there's only 3 that were confirmed to have lymphomatous infiltration of the liver, and only 7 that had lymphomatous infiltration of the spleen. And if we look below that, in dogs, very commonly, those with lymphomatous infiltration of the liver, quite a number had heterogeneous parenchyma, hepatomegaly, and less so nodules. In the spleen, we had a large number with leopard-spotted parenchyma. Splenomegaly was very common, nodules less so, and a finely heterogeneous parenchyma less so as well. And in cats, we saw a range of changes, but there's very small numbers included in the population of cats. So they went on to calculate their sensitivity, specificity, and accuracy values for ultrasonography for the detection of lymphomatous infiltration in these organs. The big take home here is the sort of the fact that in general the sensitivity is very low, especially for the liver. So it's very poorly sensitive ultrasound for detecting lymphomatous infiltration in the liver. Is slightly better in the spleen. This is probably because in the spleen we have that much finer hyperechoic relative to the liver parenchyma, where changes tend to be a little bit more easy to discern. But even still, the sensitivity was relatively low, and especially low in cats. The population of cats were looked at individually. In contrast, the specificity of ultrasound was quite high, so it's quite specific, relatively specific for detecting these changes. But because of the combination of the two, the accuracy varied as well there. But yeah, poorly sensitive, but more specific for detecting lymphomatous infiltration. When we looked at the univariable analysis, so looking at kind of one feature, the odds of positive lymphoma diagnosis in the liver was around just over 4 times greater with the presence of masses, 3.5 times greater with the presence of hypoechoic parenchyma, 2.5 times greater with the presence of hepatic nodules, and 2.26 times greater with a finely heterogeneous parenchyma. So generally having these signs meant that the odds of a positive diagnosis were higher, especially when we look at the spleens in dogs. Quite significantly, where a leopard-spotted parenchyma was present, the patient was 76.63 times greater to have lymphoma. So that's quite a strong indicator of the presence of lymphomatous infiltration in the spleen. And similarly, again, if you had a splenomegaly, there were nearly 30 times greater chance of them having lymphomatous infiltration. And both of those signs were associated with B-cell lymphomas when they did the immunotyping. So B-cell lymphomas tend to have generally more of a positive prognosis than T-cell lymphomas. Interestingly as well, when the organs were graded as being normal, if we had a normal liver, it was 3.4 times less likely to have lymphomatous infiltration, and a normal spleen was around 10 times less likely to have lymphomatous infiltration. So that's interesting as well, that when they're normal, the chances are much reduced. So discussing those results, this is the interesting kind of points brought up in the discussion and just looking at the results. So one of the things that kind of came out from it is that the paper still recommends that, especially in the case of the liver, that it continues to be to obtain samples wherever possible. So that advice still stands, and though they do note that in every case it's not always possible to do cytological sampling. There might be sort of operator-dependent reasons as people might want to do it. There might be financial constraints. There might be other conditions such as thrombocytopenia, which increases the risk of it as well. But generally, cytological sampling is still recommended. But looking at ultrasound, the use of ultrasound, they noted that it is being widely available, cheap and non-invasive. It still is an extremely useful tool for assessing and staging in lymphoma. And it's noted in the paper that on X-ray can be quite poor at detecting changes, and CT is often not that useful. So ultrasound, being able to look at the internal structure of organs and provide a method of accurately sampling, it has a real role to play in these cases. It's important to bear in mind, though, that as we've seen from the results, ultrasound has a very low sensitivity but a high specificity for detecting infiltration as well too. And again, that's a reason why sampling becomes and remains very important as well. So as we mentioned, a normal ultrasonographic appearance of the liver is significantly associated with the absence of lymphomatous infiltration, and a normal appearing spleen was significantly really unlikely to have lymphomatous infiltration. So I think those are important things to bear in mind in cases where we are unable to sample, or where we've got patients with financial constraints, so that we can use that information to see if we're seeing these organs appear normal. There is going to be a less likelihood that there's lymphomatous infiltration there. And especially as we've seen, that leopard spotted spleen was 100% specific for lymphomatous infiltration and was associated with B-cell lymphomas, which, as I said, have a more favorable prognosis as well. And similarly, splenomegaly was associated with lymphomatous infiltration. Splenomegaly is an interesting one because there's lots of different things that can cause the spleen to become enlarged, including certain anesthetic drugs as well. So the authors sort of noted in the case of the paper that splenomegaly was quite useful in cases already diagnosed with lymphoma. So I think what we're probably sort of taking from that is that if we've got a case that's had lymphoma and we're looking at them, assessing them for signs of remission, we've still got a large spleen, it still would maybe an indication that there could still be splenic lymphomatous infiltration present as well too. There's a number of limitations to the study, despite one of the aims being to look at a large population in dogs and cats. There's a very small population of cats, and I think it's difficult to draw conclusions from the paper for the feline population really at all. A lot of the conclusions that we can really kind of take from it all relate to dogs as well. They do mention they're using FNA as a gold standard for diagnosis. Obviously, there will be some limitations to the FNA and the assessment of it as well. So there might be, again, there will be a sensitivity and specificity to the cytological analysis of the FNA samples. So that might not be as accurate or as useful as, say, taking a full histopathology sample or using other tests such as immunohistochemistry as well. But in this case is what they sort of used. It was a retrospective study, so it was using still images on a variety of equipment. It's likely that being a kind of sort of university teaching hospital, that the image quality was very good and the equipment was very good, but there still are some limitations to still images. As a general point with imaging, especially ultrasound, generally those taking cine loops or videos is much more helpful, as looking at individual still images on their own can be quite difficult. The images were associated with board-certified radiologists from the same institution. In the paper, they mentioned that that could introduce bias. The agreement between them is good in their assessment. I think also part to the point of that is that if we're looking at it from a general practice point of view, it's likely that the equipment and the image quality we have access to might not be to the same level as those that they will be using. And with the radiologists themselves, it's more likely, given that they're board-certified, they may pick up more subtle changes when they're doing their grading of the images as well. So, for example, something like a finely heterogeneous parenchyma is something that's more likely to be picked up with good quality equipment and board-certified radiologists than it necessarily would be in general practice. So the clinical relevance of these changes. So as we've seen with it, ultrasound definitely plays a role in the diagnostic workup and staging of patients with lymphoma as well. But we've got to remember that it is poorly sensitive, and I don't think it really changes anything, and that sampling remains key. It's still very important to take multiple FNA samples of these organs to increase the chances of achieving a firm a firm diagnosis. However, there's definitely a role and an aspect to some of the things they've seen, especially with the leopard spotted spleen. It's a highly specific sign for what is likely a B-cell lymphoma as well. So if we're seeing that, that can help inform our diagnosis without necessarily resorting to sampling if we've got patients with financial constraints or other changes as well. Similarly, if we're staging patients, if we've got a patient coming in with lymphoma that we want to stage, if we've got a normal appearing liver, it's highly likely, it is likely that there's an absence of lymphomatous infiltration. And again, if we're seeing an enlarged spleen with this leopard spotting, it's very likely that lymphomatous infiltration remains present in that organ. So it still means that we can use the findings to possibly guide some of our decision making when we've got patients who are coming in who are we're looking for signs of remission, and especially with the changes in the spleen, it could be useful from a diagnostic point of view, but it doesn't particularly change the recommendation that still sampling remains key to diagnosis in these patients as well. So, thank you for listening. That was my quick run through of the findings of this paper. I hope you found it interesting. I hope that some of the points we raised are useful as well. If you've got a question, please get in touch. You can pop it in the Q&A box or email us at clinical@imv-imaging.com. It'd be lovely to hear from you. If you want to as well, please check out our other resources both on our website and our social media groups as well. And all that's left for me to say is thanks for watching, and we'll hopefully see you at next month's IMV Imaging Journal Club. Goodbye.